Thank you for the introduction and for the invitation to be here. So the title of my talk is Deep Learning for Cardiovascular Image Analysis. I work in the hospital, and the emphasis or focus of our work is on application, and analysis of cardiovascular disease is one of the major applications in my group. So at some point, when patient comes to hospital, they are scheduled for imaging, and then images are required, typically CT or MR, at least the images that I work on. The images, the raw data is acquired at a scanner, and that is not interpretable for experts. Then it is reconstructed to a spatial domain that is analyzed by experts. And this analysis comprises of some detection tasks, segmentation, quantification, that provides a basis for reporting, image-based diagnosis, and patient prognosis. So in my group, we focus on this last part. We take the reconstructed images, and then we try to automate the analysis that the experts are doing for patient diagnosis and prognosis. So cardiovascular disease is important because, well, it's the leading cause of death and disability worldwide. And cardiovascular events, so heart infarction and stroke, are often the first manifestation that the disease is present, while subclinical signs of the disease, so in the stage when the patient doesn't have symptoms, are often visible in medical images as a requested finding, but very often also as unrequested finding. And current medical workflow that requires manual analysis of these findings only allows very limited detection. So in most of the cases when the finding is not related to the imaging request, it is not even reported. Coronary artery disease is a type of cardiovascular disease that is caused by plaque buildup, so atherosclerosis in the coronary arteries. And this plaque can be calcified or non-calcified. At the beginning, it is non-calcified. The fat deposits in the wall of the arteries, and over time, it becomes calcified. And calcified plaque is important. Well, both of them are important, but calcified plaque is important because its amount in the coronary arteries, it's called the calcium score, is a strong and independent predictor of myocardial infarction. This means that it predicts risk of heart infarction better than all traditional risk factors combined, and independently of traditional risk factors, and those are age, sex, increased blood pressure, high cholesterol levels, and several others. And here you see a slice from a CT scan of a chest that shows, well, it is made for visualization of the lungs, but it also shows the heart. And here in white indicated bone-like structure in the coronary artery, and that is the coronary calcification. So these calcifications are routinely quantified in calcium scoring CT scans. So calcium scoring scan means a scan that is made for quantification of these plaques. The acquisition protocol is standardized in such a way that it provides the best visualization. It minimizes the heart motion, and it has no contrast enhancement, so the plaque is well visualized. Reporting this coronary artery calcium burden is now endorsed in the guidelines by the Society of Cardiovascular Computed Tomography and the Society of Thoracic Radiology, which means basically that, well, it is recommended to report calcium scoring in all CT scans that show the heart and enable visualization and quantification of the calcifications. However, it's still not routinely done, as I said, because it would have to be done manually, and calcium scoring is a relatively simple task in dedicated scans, but in not dedicated scans, it can take a long time to quantify them. Besides coronary calcifications, we know that atherosclerosis is a systemic disease, which means that if there is plaque in the heart, in the arteries of the heart, it is very likely that there is plaque in other arteries, like in the aorta, in the aortic valves, mitral valves, also in carotids, intracranial arteries. And research has shown that these extracoronary calcifications, so calcifications outside of the heart and outside of the coronary arteries, also indicate increased risk of cardiovascular events and all-cause mortality. but they are not standardly reported. So, knowing this, we have some time ago focused on calcium scoring in lung screening CT. Why lung screening CT? It is interesting because lung screening is focused on heavy smokers, and smoking is a risk factor for developing cardiovascular disease. And we have seen that in the national lung screening trial here in the US and also in the Dutch Nelson trial, the cardiovascular disease caused about the equal number of deaths as lung cancer in this population. Images that are required in the screening are made for visualization of the lungs. But if we change the settings, we show that we see that these scans also show the heart, and they also show the large vessels. So here with arrows, you can see the calcifications in the heart, the lower ones, and the top in the aorta, in the aortic arch. And when we see them, this means that we can also quantify it. In the screening settings, it's not realistic to expect that this will be quantified manually on a large scale, because in our experience in difficult scans, it takes sometimes even more than an hour to analyze one scan. So this means we have to automate it. And then we have, some time ago, a PhD student in my group, Nicholas Lessman, developed an automatic method to quantify this. And he developed a two-stage approach. In first one, he used dilated CNN to have a larger field of view, a large receptive field, to be able to to allow the network to determine where in the heart, or where in the image the calcification is located. So we were looking for coronary arteries when we separated left and right and circumflex artery, then the aorta, aortic valves, and mitral valves. But okay, this dilated CNN also generated many false positives. And so then we used another subsequent approach, subsequent network that had a smaller receptive field and worked as a false positive detector. And we have developed this method with a large set of scans, almost 1,700 chest CTs from the National Lung Screening Trial. Interesting is that or nice for us was that the images were acquired in many hospitals. So they were coming from 31 hospitals, and they were made with 13 different scanners. So it allowed us to evaluate whether the method is robust to these acquisition parameters. And actually for the patient management, the exact amount of calcium, so the exact calcium score is not important, but it is important, the calcium score determines to which risk group for developing an event a patient belongs to. And here we used 4 risk categories. That's quite standard. Sometimes there are 5, depends on the stratification strategy, but what we want to see whether patient is in low risk, intermediate risk, high or very high risk, because that determines the preventive treatment. And we have seen that, well, the method, here you see in the confusion matrix that the number of subjects that were assigned to one of the risk categories by the automatic method or by the reference. So on the diagonal, the diagonal elements show the number of scans where the automatic and reference methods agree. And the reliability of methods, so linear weighted kappa, was above 0.9, and that indicates the excellent performance. And we compared it with inter-observer agreement, and well, the experts agree a bit better, but it is very close. So you can also see here that the images are very diverse, they're very different. So in the top image is relatively easy. You can see some motion artifacts in the arteries. The calcifications are somewhat blurred, but the bottom image is very noisy, and calcium scoring in these images manually is very difficult. Okay, so when we were developing this method, and when we actually wanted to improve the clinical workflow or clinical process towards calcium scoring, we have encountered several challenges, I think, that are not specific to this task only. but generally to image analysis, and I will go into each one of them and illustrate how we address them. So first is we had to deal with image artifacts. Those were mostly low dose and related to acquisition parameters. Then what we always have to deal with is the quality and availability of the reference standard. In many cases, the reference standard is just not available, or it is very difficult to obtain a high quality reference standard. And then in the end, we had to deal with issues regarding clinical implementation. So let's first look at the image artifacts. So generally, interpretability is hampered by various artifacts. Most of them involve image noise, insufficient image resolution, and motion artifacts. And those artifacts, motion artifacts, can be caused by subject motion, cardiac motion, or breathing. In the case of calcium scoring, the problem is that interscan variability is very substantial. In dedicated scans, it has been reported that the volume difference can be up to 18%, and in non-dedicated scans that I have just showed from the lung cancer screening, the volume difference can be up to 61%. And this is hard to ignore, because this means that the patient can have scan today and tomorrow, and the treatment recommendation may be quite different. And then we look at what is causing this variability, and that indeed is image noise related to low dose, partial volume effects, that resolution is quite large, quite low compared to the size of the vessels. There is always cardiac motion present, even in dedicated scans when this acquisition has been synchronized with cardiac motion, but especially in scans when this is not done. Then calcium is causing blooming artifacts. And then, well, definition of the lesions. Clinical definition is that calcifications are areas of density within the arteries that are above 130 Hounsfield units. And combined with all the other acquisition parameters, I will show why this is actually a problem. So, but let's first look at the noise. So here you see a slice from a CT scan that has been made for calcium scoring. And with arrows, you see calcifications in the right coronary artery, and they're quite large and very well visible. And this image has been acquired with a regular dose, which is below 1 millisievert, so it's not very high dose. And on the right hand side, you see how, using commercial software, how calcium scoring is performed. Because of the definition of calcification above a certain density, the scan is thresholded, and then you see all the areas of intensity above 130 Hounsfield units. So those are indeed lesions we are looking for, but also bones and noise, and in case of metal implants, they also show up. And here you see that it's actually easy to identify which of the lesions among the candidates are true lesions that we are looking for, so indicated in red. Because calcium, well, it is always good to reduce radiation dose to patients and go lower, but especially if you would want to use CT as a screening tool for identification of subjects who are at risk of cardiovascular events, and this is something that has been discussed for the past years, it would be desired to reduce the dose. Then we had a study in which the dose was reduced 4 times to 0.2 millisieverts. And now you see that this image is well, very noisy, and in case of calcifications, in this case, it is relatively easy to see what we are looking for. But on the right-hand side, you see that actually if we threshold the image and do use the standard procedure to identify lesions we are looking for, they're connected through noise with actually most of the structures in the volume, and in this case also with spine. So calcium score is then extremely high. It's not, it just cannot be done. So what we then wanted to do is take this image that has been acquired with very low dose and synthesize image that looks like, resembles routine dose image, and then score calcium. So Elmar Woltering, sitting there, was then a PhD student in my group, designed a method that takes these two separate acquisitions and uses GAN approach to synthesize another image that resembles the real one. So you see here in the illustration, we really have two different scans, so two different acquisitions. So we couldn't use what has been done before that to take a low dose image as an input and synthesize a routine dose image using a generator. But what he then did, he took the low dose image and synthesized noise, removed it from the input image to generate denoised image, and then added a discriminator that will tell apart the synthesized image and the real image. So we don't pair the data. And what we then see is here the results. So this is the image that I showed at the beginning, which calcium couldn't be scored. And then this is a synthesized image in which you see that calcium can be scored. And this image looks a bit, it is not exactly the same quality as the routine dose image, but it is very close. Okay, so then when we look at other reasons causing the low or high interscan variability, it's a bit difficult to tell apart what is caused by partial volume effect, what is caused by motion of the heart, what is the thresholding. So if you look at this example, these are two scans of the same patient acquired 3 months apart. In 3 months, we don't expect any change or any visible change in the calcium score. If you look at the lesions, in the first one, there is almost no cardiac motion visible, and the lesion gives us high score, and the patient is assigned to the highest risk category. If you look at the scan 3 months later, there is a lot of cardiac motion visible, and if you apply the standard method, calcium score would assign the patient to intermediate risk category. Well, for one, the calcium score could not decrease over 3 months, certainly, and the treatment recommendation might be different. So to address this, Sanne van Velzen, also PhD student in my group, said, well, if you look at the image with a lesion, we can say that it is actually the healthy image without calcification plus calcium. And then she wants to find calcium without this definition of threshold and defining, removing the motion or determining partial volume in each voxel by removing the calcium from an image. So then she uses cycle gun, it transforms the image from a calcium domain to non-calcium domain and back. And what then, if you look at the detail, what she actually does, she takes a real image with a calcium, uses a generator to generate calcium map, removes this, subtracts the input image and this calcium map to get a synthetic image without calcium, applies a discriminator that tells apart real from the synthetic images, and in the backward path, just the other way around. The input is a real non-calcium image, which generates calcium, that is then added to the input image and generates or synthesizes image with pathology, and then uses a discriminator which tells apart synthetic from real images with pathology. And this is illustration of the result. So you see that in the scan there is a lot of motion. So the coronary artery doesn't look like that, and this is just based on the because of the motion during scanning. It seems like it has a star shape, a triangular shape. And if you apply clinical procedure, the thresholding, all these voxels are below the definition, and it seems that the patient is healthy, while we see that patient is not healthy. And if we apply the proposed method, then we see that the result looks much better, at least visually. And in the second scan, a bit similar. There is also a bit of a motion in the right coronary artery. If we apply the clinical method, there is some calcium, but most of it that we would evaluate visually as a lesion is not visible. And then when we apply the proposed method, it much more resembles what we would define visually as a calcified lesion. Now, if you look at evaluation per lesion, then here in blue you see the results for 30 lesions using a clinical method, and in red with proposed, and on the y-axis you see the percentage, so relative scan rescan differences. And we see that the results with the proposed method are better, but still it also shows that there is still work to be done and that it can still be a bit better. So this is something that we are currently working on. Okay, so that's about image artifacts. Then the second problem is availability and the quality of the reference standard. So for calcium scoring, we definitely don't have any reference standard and manual notations. But what I actually want to, I want to show a different example. And this is when the reference standard is not obtainable, and we use manual annotations that are also prone to intra and inter-observer variability, and also to interscan variability. And in this example, well, CT scans are in clinic mostly used to analyze anatomy of the heart and primarily of the coronary arteries. And it is considered that MR scans are used to analyze cardiac function. But actually, when the scan is already made, it would be useful to extract more information from the CT when the data is available, and maybe in some cases we don't have to acquire additional image. So this is a scan that is made for calcium scoring that I just showed in the previous example. And what we wanted here is to segment cardiac structures. This may be interesting, and especially in some cases images are acquired over cardiac cycle, so we could really, indeed, if we could do this, we could say something about function. But identifying cardiac structures in this scan is completely unfeasible. So we see here, so this is the aorta, and then, well, where is it separated from the ventricles? This is left and right ventricles. We don't really see the boundary, so we cannot even ask someone to help us segment this. But what we can do is take the images that have been made at a spectral CT scanner, because of the acquisition, which uses multiple energy levels, when scan is acquired with contrast, which is on the left-hand side, these images can the scans can generate virtual non-contrast images, so the images where the contrast is suppressed. And this is the acquisition of without contrast, and this is then virtual non-contrast, and you see that there are some differences. The quality, the dose for this image is higher, so they look better, but also the virtual non-contrast scan looks somewhat artificial. But anyhow, these images are the virtual non-contrast image and image with contrast, in which we do see cardiac structures, are perfectly aligned because this is one acquisition. And then we used this property to develop the method, which does the following. We take the image with contrast and segment that one. And then we can basically just copy the segmentations to virtual non-contrast images. It's one acquisition. There is no change in anatomy in any way. And then we can train a CNN to segment these virtual non-contrast images, and we can also apply it to real non-contrast images. So we had a study of 18 patients. It included 18 patients that were imaged on Philips Icon scanner, so multispectral scanner. And we had two acquisitions of non-contrast images and contrast, and we generated virtual non-contrast. And then we tested in real clinical set, where we had contrast and non-contrast images as two separate acquisitions. We couldn't quantify the performance in images from the clinic because segmentation is then impossible. But here is the illustration of the results, and then we have asked experts to grade on scale from 1 to 5 whether they think the segmentation is correct. And in 74% of the cases, they graded segmentation as accurate. But, so you see here in the left columns, but in the fourth one here, you see there are metal implants in the scan, and those were really problematic. We also did not train the method with such examples, and the method failed in these cases. And in the last column is, I think, a patient with congenital heart disease that had surgery, and the anatomy was completely different from the expected anatomy. And that was also not in our data set, and I think it is anyhow difficult to deal with these cases. So in this case, the method also failed. Okay. The last I would like to address is clinical implementation. So we were often asked in a hospital, a clinician would come with a set of images and ask us to develop some methods that would score calcium. And once we had a basic method that can score calcium, we could retrain the method with the representative scans and maybe tune parameters somewhat and apply it to another set of scans. Every time this required us to segment a large set of representative data. And segmenting large set of representative data is not very trivial. It requires time, it requires expertise if the images are difficult. So at some point we thought, well, okay, we have developed one method, why don't we find a way to train that method that would be applicable to all the scans. So ideally we could then, image is acquired at a scanner that shows the heart, doesn't matter what kind of image, and it would go through our software that would score calcium. So we had a set of cardiac CTs, so those are these calcium scoring CTs, which are very nice for calcium scoring, and where the experts regularly also perform calcium scoring. Then we had chest CT scans from the clinic, so these are, even though we have worked on lung cancer screening for a long time, these clinical scans are very different because they contain a lot of pathology and pathology that we don't see in the screening. So these are, the method is not directly applicable, the method that is developed in the screening is not directly applicable to scans of patients. Then we had attenuation correction CTs that it was made with cardiac spectro PET. And why is calcium scoring interesting in this set is that these patients prior to SPECT and PET get calcium scoring scans, so the most left scan to see if there are calcified lesions in the coronary arteries. And then after that they undergo PET or SPECT, which also acquires this attenuation correction CT for anatomy alignment. But if we could score calcium in these attenuation correction scans, maybe then patients don't have to undergo the first scan. So it would be easier for the patient, and it would ease the pressure on the scanner and make the costs lower. But we see that these scans are quite difficult, and they look very different than cardiac scans. The resolution is poor, acquisition is not synchronized with cardiac motion. But the fact is, as I said at the beginning, it is not really important to know the exact volume of calcium or the exact calcium score, but it is important to see whether we can assign patients to correct risk category, which then may determine the treatment. And in the last column, you see scans that were made for radiotherapy planning in breast cancer patients. And this is interesting population because treatment of breast cancer or any treatment of cancer is cardiotoxic. And patients who survive breast cancer are increasingly having cardiovascular problems later. And we have a project that is running in UMC Utrecht, where we want to see whether we can identify before the treatment which patients have pre-existing cardiovascular disease, and maybe eventually, if we can show the relation with the treatment, these patients, in these patients, the treatment option of the cancers could be optimized, having this knowledge. So Sanne van Velzen then took the method that we had previously in the group, and for which we have been acquiring manual annotations for more than a year to train this method, and then investigated whether this method could be applicable to all these scans. And then she segmented a number of scans from each of these sets and investigated how to train method, how many representative training data we have to have from each set, so the method could be applicable to all of these images. And then she has shown that indeed it is really possible to have such a method, and now we would like to plug this method in the clinic and see whether it how it performs on any scan that is made in the hospital. Okay, so why is actually calcium scoring performed? It is used to determine the risk of cardiovascular events or all-cause mortality. So when a scan is made, then analysis in form of calcium score is performed, and the literature has shown that it is not only the total calcium score that is predictive, but that it also matters in which arteries the calcifications are, whether they're proximal or distal in the artery, what is their size distribution, what is their density distribution, and that it all contributes to the prediction of the events. So we have then aimed to automate this, and in clinic it is of course easiest to use the total calcium score, and it is also easy using commercial software to see in which artery the calcium is. But it is not so easy to describe whether the calcification is proximal or distal, or whether what is its intensity distribution within an image. And Bob DeVos in my group tried to do this automatically. And then he looked at the prediction, and we see that if you use only subject characteristics, this was also in the screening, in the National Lung Screening Trial, the performance area under our C-curve is 0.69, not very high, but it improves quite a lot if we add the total calcium score, and then if you use other features that are describing calcifications, that improves a bit further, and then if we add the subject characteristics minimal that are available in the basically in the header of the image, it improves further. So yes, we have shown that we can automate this, and that we get performance that is very comparable to what has been published in the clinical research. But what we are actually then doing is what we are trying to get away from in image analysis. So we are looking at what clinicians are doing and reproducing the same to automate it. But actually images may contain other features that are important for prediction of mortality, and that's obviously, it's clear because clinical literature shows that, well, this may help or that may help, but none of it is very clear, and it is also difficult to manually perform such an analysis. But the performance is such that it remains very difficult to differentiate groups that will have an event and that will not. On the population level it works, but on the individual level it doesn't. And there are many patients who have very high calcium score and don't get heart infarction, and there are also some or a substantial number of those who have barely any calcium or no calcium and still have heart infarction. It is also possible that not all the information is in the images, but maybe there is more. So what we would ideally want is take a CT scan and run some CNN and have a prediction of a risk of 5-year event. And then ideally we would look back and try to identify in the image what has caused the prediction. We tried this and we couldn't get anywhere. Our network overtrained immediately. The fact is these images are quite large. They're 512 times about 500 slices. We have only limited number of events. Having a large data set with outcomes is far from trivial. So then Sanne simplified the approach. First, to limit ourselves at the beginning to only analyzing the heart. It is known that it is not only the heart that contributes to the events, it is also findings in the bones like osteoporosis. Early signs of osteoporosis have been related to cardiovascular events, emphysema in the lungs, and some lung findings have also been related to cardiovascular events. So it would be ideal to analyze whole image, but okay, at the beginning we focused only on the heart. And as we didn't want to design features and go through the feature engineering anymore, Sanne used the autoencoder to compress the image and used those as inputs to the classifier. So she used 3 classifiers, and SVM performed the best, but they were quite similar. And what we see here, that based only on the image information, the performance is very comparable to the same to the engineering approach, where we use the calcium score as for prediction. In this case, so this is very early work. The reconstruction, the compression of the images was not very good. So you see here that the reconstructed image here, the one that we used, and the input image are not really the same. And the reconstructed image basically only captures the major anatomy, and small calcifications were lost. In case when they were big, they were visible, but small ones that are important, and actually the literature indicates, clinical literature indicates that small calcifications, many small, are more prone to causing events, more likely to cause an event than one large calcified lesion. But okay, we still thought that this is promising, and this is something that we would like to work on further. Okay, to discuss. Well, working on this application and throughout in other applications in cardiovascular disease, we have learned that it is important when we are developing these methods that are analyzing images to question what is the problem that actually needs to be solved and whether current process can actually be improved. In calcium scoring, if we follow the clinical procedure, we see that in many scans the quantification doesn't really agree with what we would visually assess. And we would like to have that improved. And then the problem, I mean, the calcium scoring itself, we were for many years so focused on calcium scoring and reproducing what clinicians are doing that we actually maybe forgot that it is not about the calcium score itself, but it is actually about prediction of events and separating patients or subjects who are going to have an event and those who aren't, and those who should undergo preventive treatment and those who shouldn't. The problem for that is, of course, that we all, I think, suffer from is having a database that can be shared, that is well described, with good follow-up. So that is a certain limitation that I think we have to work on in solving if we want to move the field forward. And then clinical implementation is, I think, very important to have in mind also when we are developing methods to think how this can be used and whether it can be used in the clinic. Okay, thank you for the attention.